Okay, so yesterday when we left off, and I talked about preemptive analgesia, but basically the goal is to prevent wind up, and wind up again is when if we go for a period of time and we have not achieved good pain management, and then the whole body becomes hypersensitive and the neurons are firing, and the patient's going to react more even to what we call a non-noxious stimulus, which is, can be petting them on their head or scratching their ears, and maybe they react. That's what we're trying to prevent. There's a lot of differences, and again, I talked a little bit about breeds, but they can, young patients are generally less tolerant. And it was kind of funny. I remember a night in the ER, and there was a 4-month-old. It was a big chocolate Newfoundland. Oh, he was so pretty. He had green eyes, chocolate. He was only 4 months old, and he got into grapes. And all we needed to do was give him an injection of apomorphine to get him to throw up. There was probably 3 or 4 of us on that dog, and he was screaming bloody murder just for an IV injection. And of course, he's a puppy, so you're like restraining him and he's freaking out, So generally, the younger they are, they're a little bit less tolerant, a lot of times because of the restraint. They've not been to the vet. I talked about cattle sometimes are generally a little more stoic. And again, sometimes when you get into herd animals, when they're in a herd and they're out in the field, they want to try to hide their pain because, again, they are prey. If they look weak or they look painful, they're afraid they're going to be prey. So some of these animals, again, it's ingrained that I'm not going to show pain because I can't be weak. And the large breed dogs are generally more stoic than your little Yorkies and your Chihuahuas and things. And then cats, again, cats don't typically outwardly show pain. And sometimes at the clinic. Now, cats sometimes hide in the back of their cage, just normal, not painful cats. But if they are kind of hidden in the back, trying to shove themselves up the back of the cage, it's like they're trying to disappear, and I'm like, I can see you. One little technique we used to do at VCA is we used to save fluid boxes, and we would make little cat houses because, now I know this is a side note, not that I'm trying to get the cat to hide because we want to know if they're painful, but sometimes if cats are nervous, we would make them, they like to be able to get under something. So sometimes I'd make them a little towel, like a little hut with some blankets, and they could burrow. And then, I could remove that and assess the patient. But, cats tend to hide a little more, avoid owners. And a dog might be a little more clingy. So they're kind of like polar opposites. And then obviously, again, herd animals tend to avoid if they can sense that one is injured or painful. So, again, we it's hard because if you do something surgically, you're just going to assume they are painful. Some things, and I always, again, I like to ask client type questions. And what would somebody notice? Now, this could be, what does the owner notice at home? Also, what do you notice when you go in the room to do the physical exam? Definitely a change in gait and level of activity. Now, when I talked about a decrease in activity, when we talked about working up patients, remember I talked about anemia and I talked about heart disease. For me, I wanted to make sure. But again, if a patient is anemic or has heart disease, if they're anemic, they're probably pale too. If they have heart disease, they may have a murmur or a cough. They may have an accompanying other clinical sign. If an animal it won't go up the stairs and it won't go on their walk, you can also, I did accept back then for those answers, potentially arthritis or musculoskeletal pain is going to change their activity level. I don't want to go down the steps and things like that. Another thing is, and this sometimes is a very early sign of GDV, but a reluctance to lie down or shifting positions. I think we all know our animals. I can tell you places my dogs lay and the way they lay down. And so sometimes what you'll notice is, the owner might notice. Now, this is particularly key for abdominal pain. Now, abdominal pain it can be, I gave you an extreme case. If an animal is bloated, if their stomach's bloating, and I go back to, we had a dog, he was a bloodhound, and he actually was a police dog. And the owner had just gone to they had a seminar at the firehouse because they had all these service dogs. And this guy was like, it was a search and rescue bloodhound. And this dog came in and he would try to lay down and get up. And he'd get about 3/4 of the way laying down. And he kept like shifting his butt from side to side. Now, when he came in, he was not bloated in the sense, like the dog looked almost 100% normal color, normal heart rate. And because he was so big, the stomach lays under the rib cage. They can be bloating for hours and not look outwardly bloated because the stomach is being hid in that big abdomen and under the rib cage. Now, when we took the radiograph, boom, the dog was early bloat, but the guy caught it early because he's like, literally last week, I went to a seminar, but what was this dog's initial sign? He was a little drooly at home, but he's like, he won't lay down, and he keeps trying to lay down and shift. So it was a great pickup by the owner. The dog did fantastic in surgery, but mainly because we caught it really early. But the owner noticed this shifting, not wanting to lay down, and that's a sign of like abdominal pain or thoracic pain. So if there's something in the chest or abdomen, and the thing that I want you to be aware of, when we evaluate pain, especially for you guys when you're recovering patients, there is something called emergence delirium. Now, if you're delirious, you're like, I don't know where I am. Some of these dogs wake up and you pull the tube and they start screaming, and I can almost predict, like I have these patients and I'm holding them and they feel tense and they're starting to clench their jaw. And I'm like, oh God, because as soon as you pull the tube, they can vocalize. And sometimes these dogs are like, and they're screaming. Well, sometimes, remember, they're coming out of anesthesia and they're coming from stage 3. What is stage 2? Does anyone remember what we call stage 2 of anesthesia?
Is that the excitement phase?
Yep. So sometimes you'll have a dog that's coming backwards. Now, a nice recovery, just like a nice induction, they go from stage 3 to stage 1. But sometimes when they're coming out, if they're stuck in stage 2, that's what I call emergence delirium. The difference, and I want you guys for the test, how do I tell the difference? How do I know? Because when a dog wakes up screaming, 9 times out of 10, you're going to assume like they hurt. But if it's just emergence delirium, you can restrain them, pet them, and sometimes I almost have them in a headlock because they might be thrashing, they might be screaming. You have to be careful that they want to snap. And you have to be pretty strong. I mean, sometimes I've had students see me, like we had a dog wake up crazy. I was helping once several terms ago in surgery, and the dog woke up crazy, almost bit the doctor, Dr. Ritz. And I was like, I grabbed that dog and they were like, wow, you were like holding him really tight. And I could tell they were confused. I'm like, well, first of all, I wasn't hurting the dog, but that dog was about to potentially bite the doctor. And my job is, well, first of all, I don't want the dog to hurt themselves, but I don't want them to hurt me. And I've gotten an uppercut because a dog flows his head and I get a top of a head to the bottom of the jaw. And I was like, I think I gotta like snap it back into place. But when they're like that, when they're in emergence delirium stage 2, remember, they don't know where they are. This wasn't necessarily a bad dog. He was just like, what? Coming out of anesthesia all crazy. but generally it'll go away in about 5 minutes. I mean, when I was holding him, I could feel him start to calm down. I could feel him start to, and all I did was like, I was holding him, but I was kind of like scram. I was like, it's okay. It's okay. I'm here. I'm here. Now, if that was pain, if the dog was truly painful, it's going to continue. You're not going to be able to talk them off a ledge. You're not going to be able to rub their head or hold them. So the key difference between emergence delirium and pain on recovery is that emergence delirium will go away in about 5 minutes with just some gentle, with restraint, calming voice, petting them, trying to soothe the patient. That's the difference. Sometimes I put them in a dark room. I'm like, they need dark, they need quiet, they need calm. But if they continue, sometimes I'm holding a patient, I'm like, we got to give him something. Now, you can sometimes, if they wake up rough, and you have two options. If it's painful, you may need to give another shot of like butorphanol or buprenorphine, whatever pain med you used for the pre-med. Sometimes we'll give it intra-op, sometimes we'll give it on recovery. But sometimes we will give them a little sedative. And again, if I give them a little dexdomitor, or a lot of practices will use acepromazine for this, we'll give them some post-op acepromazine. Remember, acepromazine is not an analgesic, but if they are being too crazy when they recover, you can give them a little bit of a dose. It's not, and when you give post-op sedatives on recovery, you're not typically giving your pre-med dosing. Your pre-med dosing was for an awake patient. Post-op, they have drugs usually on board, so we might just, give them a little titch. I call it like a titch. You just give them a little bit of ACE, a little bit of dexdomitor, and then, again, it's up to the doctor. They can say, yeah, let's give him some more butorphanol too. So sometimes in this emergence delirium / pain post-op, you want to give them something. So what are other signs of, obviously, if an animal's painful, they might be whiny. They could be growling too, because if you get close to a painful area, sometimes they turn around and, if it's a horse and they put their ear back and they're kind of lowering their head looking at you, then, they're like, you're near an area. Hissing, all of this can be signs that, they're potentially. Now, I have had some animals recover too, and they're in the cage and they're like, mm, 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 mm. Like there's their little whine, like, and sometimes they're sensitive. Um, they might need a little post-op, a little extra pain meds after. I will say most of our patients at school, I feel like we have a pretty good pain protocol. They get Rimadyl. You guys will give them an injection of Rimadyl after induction. So they get their pre-med, and then you give them Rimadyl, and the Rimadyl injectable gives you like 24 hours of pain relief. So usually by the time they recover, they usually wake up pretty decently. But these are just things to be aware of. And again, emergence delirium, one of the key things is immediate post-op vocalization. There's usually some screaming, crying. And then look at their facial expressions, appearance, and attitude. A big thing we look for in exotics, like if you have a ruffled up rat or mouse, they're kind of ruffled and scrunched up, or ears are back. In what I'm going to tell you, and I'm about to kind of flip to the slide, in cats, and I'm trying to remember, I think it was the University of Guelph. It was in Canada, Guelph, Canada, had a really good pain doctor, and of course her name is escaping me. But she came up with a feline pain assessment based on ear position. So they had a picture, like they had a sheet, and you could look at the cat, and based on its ear position, they developed a pain scale. Because again, if your cat is nice and bright and alert and happy, their ears are typically up and in normal position. And sometimes as they start to put their ears down, like, oh, I don't feel good, or oh, I hurt, and the ear position would start to go down. And based on, so they started studying pain, measuring blood pressure, and making this assessment just based on ear position in cats. So there's a various, so when I say, when you look at your patient, do they seem comfortable? Are they sleeping well? Are they hiding? Are they cowering? Are they avoiding you? Now, some patients are not social. If you had a mean cat that comes in and doesn't want to be touched, it's hard post-op to try and interact with that cat because it's just pissed. It's not going to allow for interaction. It's a little bit easier if you have a friendly cat. They were really friendly when they came in, and now post-op they're cowering and hiding and things like that. So changes in an attitude, but looking at their facial expressions, body position. If a cat especially is sleeping on its back, or even a dog, that's a happy animal. They're kind of like, oh, I feel pretty comfortable. So pain assessment tools, they can be just descriptive, like describe the animals. Are they interactive? Are they cowering? Are they walking different? Just that's kind of what you just write in a history. There can be visual and numerical scales. There's a feline scale, but most of the thing, all of these can be used. All of these can be downloaded and used in your practice. You can, because they've all been validated. They've been studied. That's, like I said, that cat ear position. It wasn't like one crazy lady was like, let's look at cat's ears. I think it's painful. They studied all these like physiological parameters. An animal that's painful has high blood pressure. So if I'm evaluating painful patients as a study, one of the things you're assessing is heart rate and blood pressure. It's not that they're just subjective. There is real clinical data to support. And so that's what it means. These have all been validated. And one example, and then, these are in your book, so you can see the picture better. But one thing, this is a basic numerical scale. Interaction, if they're reluctant or unwilling to interact, that would be a 2. Appearance, they're agitated, vocalizing, thrashing, that's a 2. Posture, unwilling to lay down, abnormal gait would be a 2. Basically, you would assess all of this on your patient, and then they would get a score. Now, obviously, if they have all 0s, that's a 0. If they have all 2s, that's a 10. Now, I don't know if you've ever gone to the ER, or if you take your kids to the pediatrician, there's like the smiles, 0 through 10, and they're like, rate your pain. But again, we can't tell I can't be to an animal like, point to which smiley face you feel like you are. So I can assess these about my patient and get a numerical score. And some ICUs will do this every 12 hours. They will do an every 12-hour pain assessment. Most of the time there's a pain assessment like when they present. And then you can have a whole history form where you mark lesions. There's these images of the dog, and then obviously vital signs are if they're tachycardic, if they have high blood pressure, if they have a high respiratory rate. Those are all changes in vital signs. And then posture and avoidance. Now, how do we know that we've achieved analgesia? First of all, a chronic pain and surgical pain are going to be different. It's a little bit easier to achieve analgesia with surgical. We can give drugs during surgery, post-op. Chronic pain may be, sometimes these oral drugs have to build up. For example, when we give an animal gabapentin, and this is a key thing I tell owners, is gabapentin is a drug that treats neuropathic pain, basically. But it has to build up for a couple days. And I want an owner to know, you're not going to give your dog one capsule of gabapentin and the dog feels amazing. It may take a few days. But the key to the owner is I'm like, don't stop giving it, and give it on a schedule, because we're building up plasma levels. because owners, some pain meds are just give if needed. Like tramadol is a give if needed. But again, in different types of pain, it's going to be a little bit different on how we assess. But basically, is it hourly? Is it a monthly? But how do I know my patient feels better? One thing is appetite. Now, after working years and years in hospitals, you do have some dogs that are stubborn and won't eat in the hospital because you're not the owner. They don't like the food. When I have patients that are hospitalized, and sometimes oncology, sometimes I'd have patients hospitalized the whole week in oncology because they lived far away and we were doing radiation, and radiation is daily. So they literally hospitalized the dog for the entire week, or the cat. I would usually tell the owner to bring some of their food. Now, if they're at your clinic for 6 hours, it's not a big deal, but I'm dealing with a hospital where we have patients hospitalized sometimes weeks. And I'm like, and sometimes owners, if they live close, I might say, cook them a chicken breast, bring them an Arby's roast beef if we're desperate. But an animal that's eating generally feels pretty good. So sometimes inappetence or anorexia is a sign of pain. Grooming is huge in cats. If a cat feels good, they clean themselves. When a cat is ill, not necessarily painful, but sometimes one of the first things the owner notices, the cat looks unkept, ungroomed, because they don't feel like grooming themselves. Their posture and interaction, if these are improving, like these pictures I think are great. I mean, a cat that hurts is not gonna like hang out. I mean, it's got a bandaged paw, but it's kind of like chilling out, like, what's up? Come pet me. I'm just hanging out. And of course, this dog, any animal that will bare its belly generally feels good because that's a sensitive area. So generally, if they flip over, they're like, I'm all cool. So, posture, interaction are all good, especially like in cats, a cat that'll eat and groom. But again, sometimes you have to get creative with the food. I mean, we kept canned chicken breast and canned tuna. Sometimes we'd have a package of lunch meat at the hospital. We have good hospital food. We also have a box of Friskies because you have some cats that, I mean, if I'm pulling out the Friskies or the tuna, we're pretty desperate to try and get this cat to eat. I'm like, this is like McDonald's for cats. Is it ideal for your condition to eat this crummy food? But at this point, if you eat it, you're eating something, So our hospital usually kept kind of a variety of these like enticing, foods. Um, I'm going to stop there because I know you guys got to get to your other class. Do you have questions?